And with that, I will pass it over to the panel. The Honourable Tim Houston, the Premier of Nova Scotia and the MLA for Pictou East, as I'm sure you all know. The Honourable Michelle Thompson, Minister of Health and Wellness. Karen Oldfield, the Interim President and CEO of Nova Scotia Health. And Jeannine Lagassé, the Deputy Minister of Health and Wellness. So this is our panel, and I will invite Premier Houston to offer opening remarks.
So thank you so much. Thanks to each and every one of you for being here tonight. It's an absolute pleasure to be here home in Pictou County. I want to thank the health leadership team for being here and all the folks you see from the Health Authority here tonight. They've been traveling the province, talking to Nova Scotians about the state of healthcare in this province, and I think you have maybe 15 community events around the province similar to this. So I'm glad you're here tonight. I certainly know the emotions around the state of healthcare in this province. I feel the emotions here in the room tonight. So these are important discussions. This will be a very frank discussion, I'm sure, in many ways, and that's what the situation calls for. I want to acknowledge my colleagues in the legislature, Minister Pat Dunn and Minister Carol McFarland, MLAs for Pictou Centre, Pictou West. Thank you for being here. And Westville Council is well represented here, and a number of other municipal councillors as well, and of course each and every one of you. So I was elected in this constituency almost 10 years ago. And so for 10 years, the people of Pictou East have been putting their trust in me, and I want you to know how much that means to me. You're relying on me, I know that. And a year ago, just a little over a year ago, the entire province put their trust in me when they gave me the privilege of a majority government. And they did that based on the fact that I was very clear on the issues in healthcare, and that I was going to fix them. And my commitment to fixing healthcare is stronger today even than it was then. So we only say things we're serious about, and we're serious about fixing healthcare. And that's what has to happen. So even just look today, the news today about the terrible tragedy in Amherst, a young mother, a young wife, a community leader, tragically lost. And the people working in healthcare carry that very heavily. I want you to know that for sure. So the issues facing us are significant, and there are a number of incremental changes and improvements that can be made, and each one of them will have a positive impact incrementally. We'll talk a lot about a number of those tonight because there are things happening for sure. There's the problems in healthcare didn't happen overnight. They won't be fixed overnight. I think I've always been very clear that fixing healthcare, as committed as I am, will take money. It's going to be expensive. Massive investments in healthcare, and we continue to do that. In healthcare infrastructure, in healthcare professionals, in different ways of doing things. As much as it will take money, it will take time, and it is easy to get impatient, and I assure you I am very impatient, but it is easy to get impatient. And the real purpose, I think, tonight here, I think if we can leave this room and you can have just some measure of confidence that the people leading the efforts to fix healthcare are working hard, then that will be a success. Because I know there's a lot of people think nothing's happening, and that's just not fair to the people working in healthcare. If we can leave here tonight with some measure of confidence that the people leading the fix know what they're doing, even better. But we want to learn too. We want to learn about your own patient experiences. We want to learn about your own ideas. We want to make sure that discussion is free flowing. People stop me all the time, and they stop Karen as the CEO and the minister, and they say, "Why don't we just?" And we've been very receptive to say, "Okay, let's do it." There are a number of pilot projects happening around this province because healthcare professionals have said, "What if we try this?" We're trying those things. I want to assure you, nothing is off the table. We will try any idea that comes out of this room tonight. We will give it its proper assessment. but you deserve to have the confidence that the healthcare system will be there for you when you need it. And that contract between government and citizens has been broken too many times. We accept that. The Medicare system across this country is on the ropes. It really is. I mean, as much as there wouldn't be a media, there wouldn't be a newspaper in the country who's not running stories about issues in the healthcare system in every region of this country. The Medicare system is on the ropes. So we recognize that it's going to take innovation, it's going to take commitment, it's going to take leadership. And I just want you to know that I don't forget my words and my commitment to each of you. My commitment was that we'll fix healthcare. And I promise you, I will give you every single thing I have to make that happen. And the team that is here tonight and the people working in healthcare feel the exact same way. Nobody thinks it's okay, some of the stories we read in Nova Scotia or some of the stories we read in other parts of the country. It is not okay, and we know that. And we'll continue to do our best to honor our promise to you. So thank you for being here tonight. We expect and welcome your frankness, and we share your emotions over the issues with the healthcare system. So I just appreciate your presence. Thank you so much.
So good evening, everyone. My name is Michelle Thompson. I am the MLA for Antigonish. I know there's a long-standing rivalry between Antigonish and Pictou, so I appreciate your hospitality this evening. This is my first time being elected. I am a registered nurse by trade. I have about 30 years experience as a registered nurse. I've worked in a variety of different settings, the emergency room, critical care, public health, community-based care, and prior to being elected, I was the CEO of a long-term care facility in Antigonish. So it is very personal for me, healthcare, and it was a real privilege for me when the Premier asked me to serve as Minister of Health. So just to give you a bit of a quick history lesson, as soon as we started, the day after we formed government, there was a new health leadership team that was installed, and what that meant was that for the very first time in our province's history, the Department of Health and Nova Scotia Health were sitting at the same table making decisions. Prior to that, we had two entities that kind of worked. One was the policy and the funder in Department of Health. Nova Scotia Health was the operator. And while they did cooperate and collaborate, it really was not to the same degree that we see today. So our health leadership team is a very, very innovative leadership team. We're the only people in the country that have this leadership right now team where Department of Health and Nova Scotia Health are working together. They meet on a weekly basis, but certainly we are in touch on a daily basis around issues that are happening in healthcare. And that was the very first significant change, and it's been very, very helpful for us to have a bias always towards action. The next thing we did was we traveled around this province, the Premier and I, with the health leadership team. We started in Neils Harbor, and we finished in Yarmouth. And we spoke to healthcare workers. We felt it was very important that, one, we understood and validated the experience of healthcare workers in our province, and that we asked them what their experience was and what were some of the solutions, the key things that they felt would improve the healthcare system for them and for all of us and for all of you. And so we, out of those voices, which is very, very important, we built Action for Health. And Action for Health is a strategic plan with 6 pillars. It's the first health plan that we've had in this province in at least a dozen years. And it's very, very essential for us to see the path, to be clear about it, and to work towards our targets. That Action for Health plan is accompanied by a website, and I would really encourage everybody to familiarize themselves with that on a regular basis, sometimes every 3 months, sometimes annually. It depends on what the metric is. We report on how we're moving and how we're working towards improving healthcare. Some things we only measure every year, while other things we measure on a more regular basis. And also you can see retrospectively the day prior how the healthcare system is performing. What the emergency rooms, what the numbers are, what the occupancy rates are, the number of surgeries performed in the province, so that you can develop a sense of what's happening in healthcare every day. So we've been working very hard. It's been our privilege. This is the 15th or 16th session that we've done in community. So now that we're into the, into about 16 or 18-month mark, we want to get out and talk to communities, tell you what we're doing, and then, talk to you about your ideas and your solutions. Every community is a little bit different, so things that work here maybe don't work somewhere else. And it's very important for us to hear and for us to tell and get your feedback about how things are going. So this really is a conversation. The time does fly by quickly, and so we'll do our best to answer your questions and give you as much information as we have. So I'm really looking forward to the evening. So thank you very much.
I'll go. Hi, I'm Karen Oldfield. Nice to see you all here tonight. So this is my 16th, and the first thing I'd like to do is just ask all current or retired former healthcare workers to just give a little wave. So I see a few hands. Okay, great. So you guys know what's going on. I want to say thank you to the current and the former healthcare workers. We also have all those folks in the back personing the tables, I guess. I think manning's still appropriate, but at the tables, they're all spending their night here with us to, tell us what's going on from the different perspectives: mental health, virtual care, I think pharmacies back there, continuing care. So I really appreciate people from the local community coming out to share. And I want to make a comment. At the beginning of the pandemic, and if you can believe it, it's almost 3 years ago. It's almost 3 years. 3 long years. And do you remember at the beginning when people heralded our healthcare workers as the heroes, and they banged pots, and they gave them Tim Hortons cards, and healthcare workers were heroes? Well, somewhere in those past 3 years, that kind of went by the by. And now, people are frustrated. There's so much frustration as folks try to access care, or they try to access the ED. Like, our healthcare workers are taking it in the teeth. So I would just ask you all to just remember and to be really patient and really kind. They're still heroes. Were, are, and will be heroes. So thank you to all our healthcare workers here tonight. Thank you. So there is a lot going on, as the Premier said, and to give you the bird's eye view of exactly what's happening here, I've asked Bethany McCormick, who's the VP Ops, and her co-lead, Dr. Aaron Smith, to take a few minutes to just give you the scan of what's happening on the ground, and then we're going to go to questions. So would you two like to come up here? And you can certainly take my mic for one, and yeah. So, Aaron and Bethany.
Can I just before they start, I just want to mention that the reason that we're taking our masks off when we speak in the mic is that it doesn't cover well on the recording when the masks are on. We tried it a couple times, it didn't work well. So just wanted to make sure we mentioned that as I pass by.
Thank you, Nancy, and good evening, everyone. My name's Bethany McCormick, and I'm the Vice President for the Northern Zone. My training background is in occupational therapy, and I've been in healthcare leadership for almost 20 years now. In the Northern Zone for over 2 years now, co-leading with Dr. Smith, and I'm really happy to be here today with all of you. And I'll maybe ask Aaron to introduce himself, and then we'll give you some quick updates.
Hi, everybody. I'm Aaron Smith. I'm the Medical Executive Director for Northern Zone and lead along with Bethany. This is a really special night for me because I'm looking out in the crowd and I see past and present colleagues, and I see people I know from the community, and I even see one or two who used to be patients of mine when I was in primary care practice just down the road. So thank you all for coming out, and I'm really happy to be sharing this evening with you and hopefully getting lots of great information and fielding your questions. So to that end, I'll put it back to Bethany. Thanks.
So I thought I would begin with just providing a few highlights about some of our achievements and areas for improvement in our 2 hospitals in Pictou County. So Aberdeen Regional Hospital as well as Sutherland Harris Memorial Hospital, of course, serve the population here. So to provide a few highlights for the Aberdeen specifically, we have a very active orthopedic surgery program at the Aberdeen Hospital. And with that, we have a real focus on improving our wait times for surgery, but also very recently, we've had the opportunity to relocate our orthopedic clinic in the hospital down to the main level of the hospital, which provides easy access for our clients coming in and out of the building, a fresh new space that was sponsored by our Aberdeen Hospital Foundation, as well as Nova Scotia Health, to make sure that that was ready for our teams and our patients. This example of our partnership with the Aberdeen Foundation is just one of many opportunities that we have to work with our foundations. And we do want to thank the Aberdeen Hospital Foundation, Sutherland Harris Memorial Hospital Foundation, all of our foundations and auxiliaries, and our community groups that support our important initiatives. At the Aberdeen, we are also very focused on ensuring timely access to care in ambulatory care and our emergency departments. For ambulatory care, we're planning an expansion of services from 5 days a week up to 7 days a week, and we expect that to occur in March of this year. In the emergency department, we're very happy to see that the Aberdeen Hospital has the best ambulance offload performance in the province. And in fact, this team has been traveling around the province and sharing through virtual meetings and other means about this success. The success that the site has as a team from end to end, from the door of the emergency department all the way to discharge back to community or long-term care. It's really a testament to a collaborative, very active team approach, always paying attention to ensuring the patient journey is as efficient and high quality as possible. In our emergency department as well, we're actively trying a new approach that includes what's called a fast track, or a pathway for patients who come to the emergency department who perhaps have a lower acuity need. This allows those patients with lower acuity needs to access care with a second provider and allows a different physician to really focus on those high acuity patient presentations. We're seeing promising results from this, and we're evaluating how we can scale this further in this site and across the province. We have successfully implemented our hospitalist program at the Aberdeen Hospital, and this is really providing our teams and patients with continuity of care. We are refreshing and expanding in our oncology and cancer care services, and we've seen some recent upgrades in our cafeteria areas and public spaces. In terms of recruitment, which we all know is very important, our staff recruitment retention is a big focus for us. So we do have frequent meetings with all of our teams locally to understand from them how we can support staff to feel that they have the best opportunities at work, ideas from them around how to improve processes or things that we can change and improve. We have frequent meetings with our recruitment team to look at opportunities for recruitment services. We go out to universities and colleges on a regular basis to speak with upcoming professionals and tell them about the services in the zone and in at the Aberdeen and Sutherland Harris. We've had the opportunity to really build out our interprofessional teams. This is true for both Aberdeen and Sutherland Harris, where we are looking at all of the professionals that are working within a care team and really ensuring that they're optimizing their scope of practice to serve the patient as best as possible. So this would include things such as including additional clerical support, more allied health team members such as pharmacists, respiratory therapy, social work, as well as our aides, LPNs, and others. This allows every professional to really ensure that they're delivering the care that they are most best positioned to provide to the patient and family, and it has really enhanced the support of our teams. We also have a very active education and training program, and this provides our nursing staff and other professionals the opportunity for continuing education to ensure that they're providing the best practices possible. Now, just to speak a minute about some of the specific items at Sutherland Harris, we have at Sutherland Harris the restorative care unit as well as our veterans and long-term care beds. With the recent reduction of veterans needing care, we've had the opportunity to increase the number of long-term care beds at the Sutherland Harris site. And this has really provided us the opportunity to create a home-like environment for additional patients in Pictou County where they can receive long-term care in the unit at Sutherland Harris. We're working on expanding our lab and blood collection services at Sutherland Harris, and we've also had the opportunity to enhance our management and support teams at the site. We have a shared manager for Sutherland Harris and Lillian Fraser, which is just down the road, as well as a full-time assistant manager at Sutherland Harris. We've had upgrades to our patient programming related to recreation therapy, and we've had addition of other allied health members such as social work and support aides. We're very happy to have had the foundation support us to upgrade our meeting space and on-site conference rooms. And we've also had the addition of heat pumps in the long-term care unit, which have provided that much-needed cooling for our patients. So these are very great examples of the successes we have, but I do want to also acknowledge that we still have opportunities for improvement at these two sites. We continue to be highly focused on recruitment and retention, supporting our staff and physicians, and we do know that we will have to keep our foot on the gas in terms of really working with our teams around the retention component, as well as education, training, and recruitment. We also do experience overcrowding and very high rates of use of the hospitals. And so I spoke about the great work at the Aberdeen around overall site flow and the emergency department successes. But we continue to work actively with all of our partners in long-term care, home support, and others to ensure that patients can move on to their next destination as quickly as possible. I'll pass it over to Dr. Smith to speak a bit about primary care.
So, hello again. One thing I forgot to mention previously explicitly is that I was a primary care provider, family doctor for the first 14 years of my career, 14 and a half, I guess. So, I will be frank, is that we continue to be challenged with patient access in this community. We know that there are, as of the time of this report, 8,612 residents in this area that don't currently have access to a regular primary care provider. I guess the good news is we're working very hard at that. It's something I care very deeply about and will continue to care about and try every way we possibly can to improve. We are having some success recently, and that's evidenced by the fact that last month to this month, that list hasn't, actually it's gone down by 4 people, which is good. It's in the right direction. It's a 0.0% change, and I'll take it and we'll build upon it. We're working really, really hard with the recruitment team. We are leaving no stone unturned to try to get as many family physicians and primary care providers into this community. We've had some recent success. We've had, in the past little while, we've had 7 new physicians recruited to Pictou County through various streams. Some are through an international practice ready assessment program, which is supported by our local physician group. We've had 2 international medical graduates successfully recruited back to the community. We've had 2 internal or Canadian physicians recruited to the community, and we have 2 additional physicians coming in a bit later this year over the next couple of months. I will put the plug in. If you are one of those people that currently does not have a primary care provider, we have avenues which you should make use of. So your first step is to call 811 and just advise them that you don't have a provider and to add your name to the register. And once you've added your name to that, you have access to a wonderful service called Virtual Care Nova Scotia. And if you haven't heard of this, you need to. It provides amazing primary care for people that don't have access to a provider. It's provided by Nova Scotian licensed physicians. They have access to laboratory results, they can refill medications, they can give you advice. So please make use of that. What I hear sometimes is, that's wonderful, but I'm not so good with computers or the internet. One wonderful thing that's happened here through support of the foundation and as well through our local Pictou and Ignish Regional Library is at the New Glasgow site, they are supporting virtual care visits. So they have a room, they will help you get into the connected with the appointment, they'll have you all set up, and then they'll step out and you have your private appointment. So it's a wonderful service that came out of a community partnership that I'm very, very proud of. We have added 2 new nurse practitioners to long-term care facilities within the area, which has greatly improved the quality and consistency of care in those facilities. And one of our primary care clinics in town is participating in the Enhanced Access Quality Initiative pilot, which is a lot of words, but basically we're working very actively with them to ensure that their processes are as efficient as can be and to enhance access for patients to those clinics. Another couple of great programs that are happening is the Inspired COPD program has come to this community, which gives patients with COPD or chronic obstructive pulmonary disease access to high quality care and management of their own diseases. Another just hot off the press development is a partnership with the GI, or the gastroenterology service in Halifax, to improve access for patients with inflammatory bowel disease to the care and the advice they need. We have a inflammatory bowel disease nurse navigator who's going to be working with our primary care clinics in the area to ensure they have the access and advice they need when they need it. We are exploring other avenues to get people the care they need. So for example, we're supporting RN, or registered nurse prescribing programs. We had a first here in Pictou County, which is the Pharmacy Plus pilot, where pharmacists, prescribing full scope pharmacists, work hand in hand with Nova Scotia Health nurse practitioners to provide access to primary care. So that's the first time in the province. It's expanding across the province because it's been working so well. But people in this community who don't have access to primary care can also access very high quality primary care there. So in terms of the path forward, we absolutely need to improve primary care access in this community. I'll just be frank about that. But we are working very, very hard, and we all care very deeply. We are actively, as I said, recruiting, leaving no stone unturned, and we are trying to get as many nurse practitioners and primary care physicians into this community as we can. So, thank you.
I did want to take the opportunity as well to speak briefly about mental health and addictions care in the community. I am the Vice President not only for the Northern Zone, but for mental health and addictions across the province. So to share some highlights from this service, I'm pleased to say that in this fiscal year, we've had 3 new psychiatrists start in the community. We've also taken the opportunity to launch an advertising campaign that's focused particularly for Pictou County and the Northern Zone on attracting clinical therapists, so the health providers that provide counseling and support and treatment to clients with mental health and addictions concerns. We've had the opportunity to add registered nurses to outpatient teams, and this allows psychiatrists and teams to have more supports for follow-up for clients, as well as medication reconciliation and treatment programs. We've also been working closely with our policing partners in a partnership that includes crisis intervention training for police. And this increases our ability to collaborate with police around clients with mental health and addictions concerns. The Aberdeen Hospital in February of 2022 opened a new, renewed location for our Recovery Support Center, Withdrawal Management or Addiction Services. And this new center has been open and operational in the site, and it also has afforded us the opportunity to provide consult service within the hospital for folks that have addictions-related concerns in emergency department as well as in inpatients. We're also pleased to say that the Recovery Support Center will be launching groups at our local homeless shelter, Viola's Place, early this year. And also, we've had the opportunity in partnership with the Aberdeen Health Foundation and a group at Dalhousie who's conducting medical research to bring to this community a program called Forbo. Forbo is a program currently only offered in Halifax, but through this partnership, we're bringing it to Pictou County, and it's aimed at preventing mental illness and providing positive support to youth in particular who have a concern around mental health. In the zone overall, we have increased our psychiatry inpatient beds available from 13 up to 18 in the past year. And in Pictou County, we have the addition of part-time seniors mental health nurses that are really focusing on support to our elderly population, and we have enhanced our outreach services for children with autism. The Mental Health and Addictions Program provincially has an outpatient virtual care team that's available to serve all areas of the province, and we've been leveraging that in Northern Zone and in Pictou County to provide enhanced support for outpatient care. And one of the reasons that that's very important is we know that our wait times for outpatient services are still too long in this community, and we're working very hard to shorten that wait time, and part of that is through recruitment, but part of it is also through optimizing how we deliver outpatient services, the efficiency around our service process, evidence-based practices being truly followed and optimized for our clients, and that continued recruitment of our clinical staff as well as psychiatrists.
So I'm going to talk a bit about public health. As Karen Oldfield has said, this has been an extremely trying time for everybody. It's been a very trying time for healthcare workers, goes without saying, and all of us within and outside the system and community all owe a debt of gratitude to our public health departments and workers right across the province. They have been instrumental in understanding and leading our response in the hospital, in communities, in schools, in public places. And if you want to take a chance to thank them, they're right back there in the middle, and I would encourage you to do so. The good news, is COVID is with us. It continues to be with us. It will continue to be with us for quite some time. However, our response to COVID and the resources that have gone into that has stabilized somewhat. And that means that all of the public health workers who were initially redeployed to help deal with the pandemic are now back into their important work that they had been doing pre-pandemic. So some examples of that would be the early years program for children with universal screening in hospitals and home visits has started again, which is extremely important work. They've also, the Healthy Communities team has started to work with Health Promoting Schools program, looking at youth engagement, school healthy eating programs, and youth health centers. The Healthy Communities team is also supporting initiatives around housing insecurity, especially in the Cumberland area, which is groundbreaking work for them and for us. We continue to focus on monitoring communicable diseases and outbreaks. Lots of work goes into monitoring, especially this year. As you all know, it's been a very busy respiratory system with lots of different viruses and challenges going through other than COVID. They're working with our CCRCE, our local school board, to improve school reporting for absenteeism and for surveillance. Some of you may have noticed that new app and reporting system as parents, which is wonderful. And the team has also provided the first round of monkeypox clinics in December and have clinics scheduled in January and have had a very high uptake. They've been working hard as well to increase access to vaccinations and have added flu clinics as an option at the COVID mobile outreach clinics. These outreach clinics offer rural and targeted community outreach 3 days a week right across the zone. And that's targeted for temporary foreign groups like temporary foreign workers, African Nova Scotian community, Pictou Landing First Nation, locally the Pictou Shelter as well. In terms of areas for improvement for public health, we need to continue to monitor our COVID stability and respiratory outbreaks to ensure that we can keep working and providing care the way we want to, and we understand what's coming at us and how we thoughtfully deal with it. And also, one thing we learned through COVID is that we have to be ready for the next one. Whenever that happens, hopefully not like this, but so we're doing a lot of focus on emergency preparedness as well, and we have hired a new emergency preparedness coordinator to help lead us through those preparations. Thank you. And I think I tried to step back, but I think it's me for one more. Just want to do a quick physician recruitment update. So the October report for Northern Zone shows 3 family doctors and 2 specialist departures since April 1st. This is something we see. Physicians come, they go, they change practice locations. We need to plan and recruit for that to the best of our ability. There have been, however, locally 14 new physician starts right across the zone, with 4 more pending. So since April 1st, we've had 8 family physicians recruited to the zone, 1 in Amherst, 2 in Elmsdale Truro, 3 in New Glasgow Stellarton, 1 in Shubenacadie, and 1 in Tatamagouche. Also, since April 1st, we've added 6 specialist physicians to our medical staff across the zone. In Truro, we've added a pediatrician, 2 psychiatrists, and 1 surgeon. In New Glasgow, we've added 1 internal medicine specialist and 1 surgeon. But we will, as I said, continue to recruit heavily and try to get providers into the gaps that we have. Thank you.
Thank you, Aaron and Bethany. And so for the next portion of our evening, we are going to start taking questions from the audience and from the pre-submitted questions. And what we've learned over the last number of months as we've done these conversations is that in order to make sure we can get to as many people as possible, that if someone else has asked your question or a very similar question, to maybe allow someone else to ask a different topic. If you have something that's really pertinent that you really want to hear about, you can write it on a card with your name, and someone from this leadership team or their teams will get back to you. And so sometimes, many times, we run out of time at the end of the night, and it's really awful when you're, as for me, it's awful for me, it's all about me. But it's hard when you know people have questions and we can't get to them because we've run out of time. Please be assured, if you write your name and your question on a card, someone will get back to you. So those are kind of my 2 kind of, I guess, I don't know, it's 2. Anyway, those are kind of the ground rules, if that makes sense to everyone. Everyone's okay with that? So what we'll do is we'll get you to put your hand up if you have a question. I'll point, and I always do I know it's rude to point, but I don't know how else to do it. And we've got runners with the mics that will come to you, bring the mic to you if you have a question that you want to ask. I'm going to start with one of the submitted questions because these are questions that people wanted asked that are in the room, but wanted them to be asked on their behalf. So I'm going to start with that, and the panel will choose amongst themselves, I think, who will answer the question. So this first question is submitted. Are you aware of the fear and dread of the population's experiencing and the abysmal lack of confidence people are experiencing daily?
So I am very grateful for the person that submitted that question, because I know that there is a heaviness and a worry around healthcare. I think we've all felt it for a very long time, and it really is the reason that we're coming out and we're speaking to community. We want to be present. We want to tell you about the things that are happening, and there is a lot of good happening. I know there's a lot of work to do, and that's why we want to come out and talk and hear directly. I will tell you I've been in healthcare for 30 years, and I appreciate that I am biased, but I have really never seen this commitment to healthcare. Over the course of my career in particular, it has always been around change, but with with an intent to take slack out of the system or find efficiencies or find ways to, but this is a really historic investment in healthcare, not just financially, but in resources. I think, when we did that tour for the very first time, to go around and hear directly from, thousands of healthcare workers about what they need, I think is very encouraging. And for their voices to be the foundation of the Action for Healthcare plan. The people that are working in our healthcare system are dedicated and devoted, from pre-hospital care. Our EHS colleagues, there's some folks in the room tonight, are the best trained paramedics in North America. We should be very proud of the training and the care that they're able to provide. Right to the work that's happening in long-term care, all through acute care into long-term care. And for the very first time, we have a minister of long-term care, seniors in long-term care, who is really devoted, and we have a department looking at how we care for seniors, not only in long-term care facilities, but in community. So I want to encourage people. I'm going to let my colleagues speak a bit about what else is happening, but I am very proud of the work that's happening. It is going to take some time. We've been digging through this hole to understand where the gaps are, And we know now. And so we are going to incrementally work very hard through investments and through, innovative ideas. We have a lot of great things that are happening here. And in fact, when we travel and we talk to our colleagues across the country, they're very interested in the work that's happening here in Nova Scotia. We're small enough and we're nimble enough, and our health leadership team is together, and we are making some strides, and those are the things that we want to talk to you about today. So I want to acknowledge that worry, and I want to acknowledge that fear, and I also want to encourage you that we are very, very committed and focused, and we do know we have a lot of work to do, but the Premier has given his word, and I give you mine, that we are going to work on your behalf to improve and fix healthcare in this province. So I think probably there's others folks that want to chime in on that, but I am very grateful for someone for naming that in the room tonight. So thank you.
Thank you, Minister, and thank you for the question. It is an important one. People say, for example, if I call 911, is an ambulance going to come? Is somebody going to come? Is it going to be 9 hours? So I understand the concern that when I need some help, will it be there for sure? And just to take that EHS part, I mean, we know there's work to do. I read about those terrible situations too, where people wait too long. The pressure is still on the system in very significant ways. But there is also positive action that's happening. So one of the first things we did, we hired, I think, 100 patient transfer drivers. So when you're going from one hospital to another hospital, you don't need a fully trained advanced care paramedic to drive you. So we hired 100 of them, and I think we just we're going to have 180 more we're hiring now. So the results we see on something like that, of the number of transfers that happen, have been reduced. The ones that have been done by advanced care paramedic or a highly trained healthcare professional have dropped 75%. Well, that means those people are available to respond to 911. We've also worked with kind of the triage system when you phone in. Sometimes now it might be a single person coming in the unit to care for you because they've had that discussion with you and they've had an assessment. So that frees up other people. So look, we understand the concerns about will the system be there when you need it. Those concerns, I accept those concerns, but I also want you to know that there are things happening that are improving access. It's just a long way to go, but we're committed to getting there.
I just would like to add that I've been with the minister now for just over 15 months. I became the deputy minister just when she became minister, but I'd been in the Department of Health for the 4 years previous to that, and I've been with government for 26 years. And I can tell you the commitment of the minister and the premier to action for health is like I have never seen before. And I really would encourage you, as the minister did, to go to visit the Action for Health website if you can get access to it, because it is a very comprehensive plan that takes into account the fears and concerns and the ideas and the innovations that we have heard over the first year that since the minister became minister. So we acknowledge how you are feeling, and we want you to know that we are innovating every day. We are trying things as quickly as we can. We are moving as quickly as we can to improve things, but it will take time, and but we also want to be held accountable for it. And that's what the Action for Health website does, is it shows you exactly where we are in achieving the things that the government has said that they will achieve.
Just a final thought, and I guess where this comes from is, I'm kind of the newbie to the health system, not to complex systems, but to this system. What I would like to share is two things. First of all, for whatever reason, the long-term planning required to account for the day that we weren't going to have enough nurses, to account for the day that we weren't going to have sufficient family doctors. I don't know why it didn't happen. Okay? It didn't happen, guys. So, it was known 20 years ago that this day would come. with respect to nurses. I'll just choose nurses as one, but I could choose any number of medical professionals. So if I say we started behind the 8 ball, we started behind the 8 ball. So then we got another thing we got to worry about, which is, you've heard of this demographic called the baby boomer? Do we have some in the room? So what this looks like for us is not pretty, because the next 25 years of boomers and the needs, so whether it's hospital, whether it's access, whether it's long-term care, you name it in the system, we have had to come at this triple time, and it is going to take time. So we've all said the same thing, but here's what I want to share. The government is throwing everything at it, like literally everything at it. The political will is 100% there. The money is made available, not to flush down the toilet, but to be used for smart things. And somebody said earlier, I think it was Bethany, talked about, she had a list, but one of the things she talked about was clerical workers, as an example. Let me tell you something. In 2011, 2012, 2013, all of these people that do all of that great work, well, when budget cuts came, so Pictou County, Nicole Boutlier would tell you if she was here tonight, she's not here because she has COVID for the first time in 3 years. So she would tell you that they were asked to take $8 million out of the budget of the health authority and not touch the front line. So what happens? There's a lot of admin that gets gutted in those circumstances, but these are really important people. So now who's doing that work? It's nurses or LPNs or you name it. So one of the first things we're doing is putting those people back in place so the nurse can do nursing. And I just use nurses as the example, but we're going to talk about scope of practice tonight. That's just one example. So we are coming at this with everything we have, okay? But we can't wave a magic wand. So I got a 5-page letter today from the NSGEU, actually. You got it too. You probably didn't see it yet. You got it too. Anyway, about suggestions, solutions for things that could be done in the ED. This is in Halifax. So I say, bring that on. Like, we may not be able to do them all, but if there's anything good, we're going to do it. So this is sort of, hopefully we do get to some solutions if we stop talking. So I'll go over to you, Nancy.
Can I say one more thing?
Yes.
I just want to add as well, like for a long time in Nova Scotia, our young people had to leave, right? They had to leave and go other places to work. And what I would encourage everybody in this room, if there's a young person or someone who's, looking for a change in career, we say health is where it's at. There is opportunities in every community across our province for our youth to work, not just as nurses or physicians, but, in those clerical positions, in allied healthcare professionals. Like, this is an opportunity for us to work. And I know we hear many negative things, but I want to assure everyone in this room and healthcare workers will know that working as a healthcare worker is a noble and meaningful career, and you get back tenfold what you give through the work that you have with patients and families. So if there are young people in your life, I would just please ask that you encourage them to look at the different healthcare professions as a possibility to keep them home and to raising their families and living in Nova Scotia, because there's so much opportunity right now for Nova Scotians.
Thank you. Okay, so now we're going to turn it over to see if there are questions here in our audience. And look, see, it's always like, I do want to say, like, getting your hand up first is really strategic, because I find as you get closer to 8 o'clock, there's like a whole bunch of hands up, and then we're kind of counting people off. So back here in the corner, and I'm doing my pointing, and we've got thank you.
Thank you. It's just as to our conversation we just had about our young people. There's many smart young people in our province that would like nothing better to get into medical school. I know how many in the past have had to go to Europe or wherever to get their training. This question's been asked to you several times. I've heard it in town hall meetings. So I guess I just would like to know, what are you doing about putting more of our young people into medical school?
Well, thank you, Gary. That's a great question, and it certainly is something that it's a question that I have as well. You know, you have a student who has a 99 average and doesn't get into med school. What's the difference between a 99 average student and a 92 average student, for that matter? So listen, this is one of the. I'll just speak freely. It's been a frustration with our medical school in this province at Dalhousie, who, you know, we have a lot of discussions with Dal about making sure that you're training healthcare professionals for Nova Scotia too, not just training them to go somewhere else, and not just taking people. So this is part of. You might have seen some discussion about an investment the province has made in looking at the feasibility of a second medical school at Cape Breton University. So we've invested in that feasibility study for a couple reasons. We think, well, first off, CBU came to us and said, we'd like to train healthcare professionals for Nova Scotia, for rural Nova Scotia. So that definitely got our attention, and I think the competitive nature between two schools would be good for us to have a more receptive. So, you know, look to all the Dalhousie graduates in the room and the people who are at Dalhousie. We love Dalhousie being in Nova Scotia. We just want a little bit more from them in terms of training healthcare professionals that work here in Nova Scotia and giving our students an opportunity. So that's one thing we're doing. But there's the other part of that is around where they get their residency. You know, when you graduate from medical school and you have to do a residency program. That's a national program that matches people up. So we're working with. I think it'd be fair to say we're working with the national registry to kind of tweak the criteria a little bit so that we can actually attract maybe a Nova Scotian that even went to medical school somewhere else. Give them an opportunity to do their residency here in this province and open up residency spots. Karen's saying 10 or something. I don't know. But listen, totally agree with you on. We have a lot of smart students in our school system, and a lot of them want to be doctors, and they should have that opportunity, particularly at the universities and the medical schools in this province. That as taxpayers, we're spending a lot of money to keep going, but I think the relationship has got slanted away from each of us. And as a government, we're trying to slant that back towards us through a couple things. But that's a great point. I thank you for raising that.
So I'd like to add to that. So agree with everything the Premier just said, but just a couple of thoughts to keep in mind too. So, like the first year class, say at Dalhousie right now would be 128, of which I think 85, if I'm not mistaken, are Nova Scotia students. So this is a good start, okay? And so we work with Dal to bump that up. Like, I want all 128, but work to bump that up, number one. But number two, and here's the key for a community. Just because a Nova Scotian gets into Dalhousie Medical School doesn't necessarily mean that person stays in Nova Scotia, okay? And you know, the world is a doctor's oyster these days. The world. They can go anywhere. So we really, really have to work hard to make sure we're into the classrooms to tell folks how great it is. Make sure they know they have a job. The day they start medical school, they get their offer. So when it comes to a community, though, you know, it's really important to support the efforts of the recruiting team, and different communities across the province do it differently, and some have greater success than others. There's things we can learn We have to be open. And we have to make sure that people know we want them. Like, we can't be not nice in the ER. We have to be the contrary. We got to be like, help them. We got to invite people home for dinner. So the other part of it is, which the Premier just alluded to, so to do a residency, you got to go through this thing called CARMS. And we have had a breakthrough with CARMS and Dalhousie. So for Nova Scotians who have been educated outside of Nova Scotia, so perhaps they went somewhere in Ireland, and we got tons of Nova Scotians going to school in Ireland. They just can't come home. They can't come home because they can't get a residency, because they haven't been matched. Like, it's a complicated thing. So we've worked with CARMS and DAL so that we now have a stream that's just for those people. So folks who have gone and gotten their medical degree outside of Nova Scotia, they can now apply to that specific stream and have a much increased, much higher rate of having a chance to get their residency here in Nova Scotia. So this is a good thing. And we're just getting started on all of that stuff. But we're making our breakthroughs.
Okay, thank you. Any other? We have lots of submitted questions too. Oh, see, this is great when everybody starts going up. So this is when I start doing counting, just so you know. So we'll start counting off. So I saw a hand over here, and then so we'll do one. So kind of 3 in a row right there, and then we'll make our way over here because I saw hands here. So we'll have, yeah.
Thank you very much. As mayor, I just want to say, before I start my question, welcome to all of you. We appreciate you being here, and welcome to all residents and non-residents of Westville. My point, or my question, I guess, follow up on Dr. Smith's recruitment numbers. I recall attending a meeting with the department in 2017, November 2017. I checked my notes before I came, and it was reported that we had 29 family docs in Pictou County. I'm talking Pictou County now. We had 29 at the time. 29. And by the estimation, and I don't know where these numbers come from, but we were short 6. So I'm just curious, number one, as to where we stand in relative relationship to those numbers from 2017, when we were informed at that meeting that we had 29, and we required 26 more family doctors, I'm talking about. I'll leave that question, but I wanted to comment on Karen's comment because I was going to ask that very question. What can we do as a community in Pictou County to help with the retention? I know we can do some things we can't do a whole lot with recruitment, I don't think, other than be the nice, welcoming people that we are. But when they come, what sorts of things specifically can we do? It takes a village to raise a child. I think it takes a county to raise a doctor and keep him here, or she here. And I just want to encourage people, as you have, Karen, I want to encourage everybody here, when you go to see your doc, and particularly if he's a new doctor, or if he's a resident, or she, I should say, he or she is a resident or a new doctor, talk to them and ask them, how long you've been here, where you come from, a little bit of information, and say, we are so pleased and happy that you are here with us, and we need you to stay. What can we do as a community to get you to stay? Thank you.
That would be a great start. And, I don't know what organizations you have specifically in your community. If you don't have one, which I'm sure you do, I'm sure there's some organization or association that can kind of put this top of the list. It really needs to be top of the list. So other parts of the province, people do a whole bunch of different things. But, it's not just the physician. It's also the physician's family, okay? So they got to feel good about it all too. And I would just share that when I look at the stats, and I don't know the answer to the question from 2017, Aaron might know it, but if not, we can easily get it. I just don't know it off the top. But when I look at Pictou County, there's been in my mind, quite a rotation. People have come in on return to service agreements, and then the return to service agreement is up, and then they leave. They go back to their home province or to another province. So, you know, we do exit interviews. Most of those situations, they're personal. It's nothing that a community does or doesn't do. It's personal. They want to be home with their family. They're ready to have children, and they want to be near their grandchildren or what have you. It's not, you know, we can't take it personally. However, I think it does go back to recruiting, and it does go back to the fact that if we have people, the more Nova Scotians, the more Pictou County folks we can put to medical school, the greater the likelihood that they're going to come home to Pictou County. That's just a fact of life, okay? So what the minister said about recruiting early, identifying those stars, finding co-ops, like this is not just a, you know, the doctor's here, great, let's invite them home for dinner. This starts at a much earlier stage, and it requires a strategy. It really does. So I would encourage that thinking, and I'm happy to sit, you know, we can sit down with whatever group wants to go through that and see what it looks like and do best practices vis-a-vis other communities in the province too. So there's a lot of good stuff going on, and it works. Different things work for different communities. So start that. I'd say that.
So thanks for the question. I'll get back to you on the exact numbers for sure. It's a moving target. We know the reality of physician recruitment is somewhat different than maybe it once was. So we've all become very used to recruiting a physician, and they come and they stay and they work in their office until they retire, and that's it. And what we know now actually is as we recruit young physicians and new grads, they tend to move and change practices on average between 3 and 5 times before they settle down. I wholeheartedly agree with everything that's been said. We don't recruit physicians or other healthcare providers or workers. We recruit families. And you know, how those families land in our community and how they're supported is key to our ability to retain those providers. So, you know, I feel strongly it's on all of us individually and as communities to increase our competencies and skills in welcoming people from diverse cultural backgrounds. We need to do it if we want to succeed in the health economy, but also more generally. The other thing about you know, physicians that come and they move, or we have return of service agreements, I also feel it's very strongly that we need to understand how physicians and other healthcare providers want to work, right? You know, they may be very interested in family practice only. They may be interested in doing some emergency work. They may be interested in doing supportive work for chronic disease. So it's really on us as providers come through to capture what they want to do, capture that innovation, follow the leads of good ideas, and support practice models you know, that are important to them. So we're working very hard at that. Thanks.
I think the only thing that I would add to that is, in addition to knowing, we know that physicians now practice differently than they did even 5-6 years ago. Like the things have really changed. It also leads into how we pay them, right? That there's different payment models that we need to look at. And so there's a whole number of things that go into this. So it's about finding people, yes, and getting them to the community, but there's a whole range of things that need to go into it. So we are looking, for instance, at different payment models now to say, okay, if someone wants to practice in this way, in these different environments, what is the best way for us to pay them as well? So we're looking at everything that goes into the recruitment and retention.
Thank you. I think we have here next, and then I keep doing the count so I don't lose it, you know, right there and then there.
I'm sorry, is there somebody else first?
No, it's you. It's you. Thanks.
Does this work? Okay. First of all, I want to address this point. All of our health workers are still our heroes. I don't care what anybody else says. And if you go into that hospital and you treat them like heck, boy, you better get ready. They are our heroes. Don't ever forget it. Now, really, I want to address what I would call a systematic problem. I had an opportunity to spend a night with a family member who was I would say suicidal. Mentioned it a few times. We went to the outdoor. The professionals inside, I got no problem with what happened there. It was a long wait. Yes, it was. It was a long wait. I think it was 6 hours. That's fine. I don't mind doing that for a family member or a friend or a neighbor. I don't mind doing that stuff. That's okay. What happened afterwards is my problem. She reached out to the medical system many times. Always get the little treatment and then out the door. But her GP had given her a specialist who spoke briefly over the phone with her, prescribed some medication that was wrong, the wrong medication. There was no follow-up. And when things started to blow up in everybody's face, we get in touch with the professional again, this I shouldn't say so-called, I guess he is a professional. But we were told that he's washing his hands of us, and he wants us to go back and start from the very start. And when he was asked why, well, that's policy. Not he, I guess, for the lack of a better, his office, we'll say that, because it wasn't him personal. At that point, she had never spoken to the man in person. But yet they can turn around and they can just say, no, you go start from the start when they're in a suicidal situation. Is that a systematic problem with this? If it is, fix it. Can you give me some sort of insight on this? Because, you know, I'm trying to deal with it, she's trying to deal with it. It's not very nice.
So I think there's a few things there. I think it's really important in terms of, making sure that people get the right care from the right provider at the right time. And, I think maybe Bethany may have some other things to add. So we are looking at how do we provide universal mental health care in this province. And the Premier, that's a brainchild of our Premier. He talks about that so that people can access the right provider that they want in community. The other thing that we hear particularly from people who live with a chronic illness like a mental health issue is that every time they go somewhere they need to tell their story over and over again. And so care becomes very disconnected and disjointed as a result of that. And it's exhausting for people to have to retell their story. And so what we're looking at is one patient, one record, so that as we enter the healthcare system, that everybody in the care team will know the story, and we can connect people in a different way so that patients don't feel like they're starting from scratch every time. And we also want to look at how do each of us have the opportunity to have our own access to our own medical records, so that if we do access a care provider that doesn't know us, that we have the information that we need. So I'm going to get Bethany to talk a little bit around some of the supports, but if there is a particular concern, it's something we can talk to you about afterwards to better understand. But we are looking at integration and how we make sure that people can access the right provider at the right time.
So maybe just a few thoughts. What I think I'm hearing you describe is, an individual that's been referred to a specialist for opinion or support in the mental health system. And so typically what would happen is we would match the patient's need to the right care provider as the minister has described. And for psychiatry in particular, if that's where this individual was referred, they would be, providing consultative support, input into the care of that patient, and providing a treatment plan, and that would typically be followed up with the GP or the family doctor and the patient's care team. Sometimes that's time limited, and other times it's more extensive. It depends on the case. Be happy to follow up with you individually about more details. But one of the things I did want to highlight is through the Universal Mental Health Initiative, we're looking at new partnership opportunities for support with community-based organizations in primary health care, supports that individuals can access through various means. So recently we launched Tranquility, which is an online support service for people with early mental illness or need support before their illness becomes too significant. We have peer support lines and various avenues. So having more wellness and early treatment options available is something that we're investing in. The other thing that we have and we're exploring is what's called a virtual hallway. So what this does is allow us to access specialists across the province and through various means to do consultation with a patient who needs a psychiatrist, for example, or another specialist to weigh in on their care plan and provide advice without having to have that patient travel, so we can offer a more comprehensive care plan to that patient. And I'd be happy to chat with you afterwards if you have additional follow-up.
Okay. She's stealing my mic. She's going to steal my gig from Bethany. Thank you. Thank you. Okay, so we have some back here. Again, I'm doing my pointing. I think she, sorry. We're all very polite. I was laughing at another session we were at. All these polite, everyone's very polite. So people probably have a sense, but I think she was next. Sorry. And then I think there was someone over here, and then we'll get back to you. Is that okay? Okay.
Oh, hi. So, a little personal story. About a year ago, I got COVID, like many of us have, and ever since, I've been suffering with pain in my head. So, I've been seeing a nurse practitioner, which did get me into a specialist in Antigonish, Dr. Clifton, but he said, I can't do anything about the pain in your head. I recommend you see a neurologist. So I've been waiting now for a year, and I did call the office of the neurologist, and they said, yes, we have your name. It's a 5+ year wait. I'm like, I suffer every day. I'm taking pills that I don't know how they're going to affect me, and I just don't want to be the statistic that you mentioned, a woman in Amherst. I just don't want that to be me. So I don't know how much more, what else I can do. I've been waiting over 6 years now for a doctor. I've been on the list or whatever for Nova Scotia, but I know many people have had doctors ahead of me, and yeah, so it's frustrating and it's scary, and I'm in my 50s and I want to see grandchildren and everything one day. That's all.
I'll just, first of all, empathize. Like, it's just so frustrating. And then you call and you email, and you get the voicemail, and nobody gets back to you, and so it just further aggravates the situation. So what I would like to do is just speak to me after, please. Give me your name. We'll see what we can do. I'm not saying I jump lists. That's not what I'm saying. But let me understand your case a little bit better, and then we can get to help find a solution. So, yeah, thanks.
Can I also just talk a little bit about some of the optimization work that's happening? So there's some folks that have, we're looking at how do we support clinicians who have long wait lists. So we're looking at where are the opportunities for us to go in practices, not just GP practices, but in some cases specialists. So we can go in and look, what? We all answer the same question sometimes, so I don't know. So we are looking at ways that we can support clinicians, because the list can get really long and then it gets more difficult. So even our Need a Family Practice list, that really is simply a list of names. And we want to look at the functionality of that list so that we can triage people appropriately. We can make sure that, there's access available. So the digital solutions that we need in this province are going to be a significant investment, and we've committed to those. But we do have a team of industrial engineers and folks like that who can go into practices and support clinicians in being more efficient, because it can get really long and it gets overwhelming. And, there is a special knack in terms of how we manage all this. So it is important that we hear, a little bit more about your case, but there is some work underway for those folks with long wait times to support patients as well as the clinicians.
Jeannine wants to talk about e-refer. Oh, sorry.
Just on
Go ahead,
that,
Premier.
I think I'm really sorry that I didn't know that, but I think the point is that the doctors, the specialists that refer to other specialists, they're humans, so they tend to refer to somebody they know, right? So that neurologist may have a 5-year wait list, but there might be another one who has a 6-month wait list, right? But it's not, you just got on that list, right? So this is part of the optimization, was the word that the minister used about making, so we can see a central list, and well, there's that list is too long. What can we move some of these people over here, right? So there's a bit of that has to happen too. That's technology and stuff. So I mean, talk to Karen afterwards, and we'll see if we can. That might be part of the solution.
Yeah, Premier really said what I was going to say. I just wanted to say we've started specifically to in surgery, right? That's one of the areas where we know we have really long wait lists and wait times. And so there is projects underway that have started within the last year for a single entry access place to exactly get to what the Premier was saying, so that people can find out where they are on the list. And then when you get to the top of the list, or if you're partway down the list, but you've said that you would go somewhere else in the province potentially to get your care, then we will know to contact you to say, if you want to stay on this list over here, it might take you a year, but if you're willing to travel over here, it might be 4 months. And so we're implementing these solutions to be able to get to the heart of being able to get people the fastest care in the most appropriate place.
But will that stop specialists from removing people from those lists? That was my question. Is it policy, after speaking once on the phone, writing up a prescription for what your hands of the person you're talking to?
Look, I don't think that's a policy, but the reason we kind of want to have a little discussion afterwards is because that may have been all that specialist I could do. You know what I mean? So we just need to understand the circumstances. But I think that the fair point that you're making, and especially around addictions and mental health, which, you know, we have huge needs in addictions and mental health. We did create the first minister in this province of addictions and mental health. And I call it addictions and mental health, not mental health and addictions, because I thought in the fullness of time they just drop the addictions part off and you'd just be so. But the point is getting to the right person that can provide the right care. So if somebody enters the system at the wrong place, they're not going to get the right care. And we have people entering the system at the wrong place because they don't have a family doctor. They're going to the emergency room or whatever. There's all kinds of examples. So we need to. These are systemic, I think was your word, but there are structural changes that are needed to make sure that when people get into the system at the right place, they get the right professional. And just on addictions and mental health, the program that we're working towards is universal, universal mental health care. And look, addictions and mental health is one of the areas where we have a two-tiered system in this country. If you have great insurance or cash in your pocket, you can find a private psychiatrist, or you can find, but if you have to, maybe you'll get in a little quicker than if you're on the public system. So what we're trying to do with the universal aspect of that is just mobilize the entirety of the resources. So even if it's a psychiatrist or a psychologist who's hung their shingle out and they have a private practice, they would be able to take patients from the public list and build the MSI system. So in that way, we would improve the population of people that are providing care to the public, and hopefully improve the opportunity to get somebody to the right care. So we don't know the specific circumstances, but if the treatment program for a person requires a monthly meeting or a weekly meeting or a daily meeting, and they end up on the patient list of somebody who just doesn't do that, then they're probably going to be told to go somewhere else. And we don't want people being told to go somewhere else unless there's a plan for them to go. So I'm really sorry that has happened from start to finish. When somebody reaches out for help, that's the time to give them help, and that's not happening. So I understand the concern and the anxiety over that. But is it a policy for people to drop patients? No, I don't think that's a policy.
No. And, one of the things that, I was basically shocked the more I dug to the bottom. So Nova Scotia Health, as an example, I don't necessarily know that specialist list. I don't know that neurologist list necessarily. I don't have a peek into it. I have no idea. So one of the things that our work on the technology will do is integrate that so I can see and we can smooth it. Okay? It's just, don't ask me why, it's just an is, but it's getting fixed.
Okay, so we had someone in the back here. Oh, lots of hands going up. Back here. And then we had some over here. So I'm going to say it again before we get really, really busy towards the edge of it, that if we don't get a chance to ask your question, please write it down and someone will get back to you. And I know sometimes it's good to be able to ask it in front of the group, but we may not get to everyone. But we've got someone in the back here first. Thank you.
I want to thank you for having us. There's a bit of a preamble to my question. In my opinion, this province is unfortunately violating laws and acts that run our society. Mandates are not law according to Black's Law Dictionary. They are merely recommendations. There are violations of the Personal Health Information Act, the Canadian Charter of Rights, Section 7, the Canadian Bill of Rights, the Canadian Genetic Non-Discrimination Act by force testing employees, and the Nova Scotia Human Rights Act in regards to discrimination based on a protected characteristic, which is an irrational fear of contracting an illness or disease. A Nova Scotia FOIPOP, or Freedom of Information request listed at shelleyhipson.ca, states that there have been 0 cases of asymptomatic spread in the province. Therefore, if someone is not presenting symptoms, they should not be treated as though they are carrying an illness. If citizens are not able to return to their professions in healthcare based on their private health decisions, that is discrimination. I assume that is why the rest of Canada has permitted unvaccinated employees to return to work, aside from Nova Scotia and British Columbia. So my question is, why is there no accountability in regards to these violations, and why are we not hiring back unvaccinated healthcare workers, especially given the data we have now that suggests the poor efficacy of the vaccines, the many adverse reactions, and the fact that they do not prevent spread of COVID-19? I have heard you state in previous conferences that there are only a little over 100 unvaccinated healthcare workers. I don't believe that this number is accurate and does not reflect the actual number, as many citizens that I know have left work without providing their health information. I know there would be more interest in citizens getting into healthcare if there were no more mandates, and I think the fact that this could save many lives should be taken more seriously. Thank you.
Thank you. Thank you for your comment. And actually, that is a comment that we've heard pretty much at 15 other sessions. So all I would say is I appreciate where you're coming from. We always look, but at this moment in time, that's our policy and we're sticking to it. So I will just take it under advisement and go from there.
Thank you. And I think we had, did you have a question still? Or is it the same? Yeah. I know the pointing, right? I think it was you. And then, sorry, who did you see next?
Oh, yeah, okay. Pull my earring off here. Thank you very much for this opportunity. My concern seems to be very puny when I hear of people who are suffering a great deal. But it's kind of to follow up on what you were talking about. I hear a lot of and you're doing great, by the way, the initiatives we are doing. And then I hear you. Can we join that together, make it an us? So, and it's really getting the community more involved. The very first question here, the dread and the despair in that question broke my heart. And if we could be more accountable, us as a community, I think we would feel a lot more comfortable. So things such as, if we could find some wonderful talent from another country, can we get our immigration officials involved in setting up accommodations for them, translators so there's no mistakes made on prescriptions, our new grads coming out of DAL, if we can find residencies for them, that's wonderful. But the practical thing would be to look that, they have to live and pay that student loan. Perhaps some of that could be forgiven for a formal commitment to our healthcare system here in the province. I could go on and on about sitting in an emergency room and not understanding what's going on. Perhaps a simple video to help patients that are sitting there wondering what is the protocol might help them understand better, and they could be more cooperative and, really participate perhaps in, the well-being of everybody in that emergency room. So, workshops, videos, more education. Is there a database somewhere where we could tap into things like this? Make us accountable. We're part of this health system too. Thank you.
You're talking our language.
Yeah. Well, thank you so much for that, and some great points in there, particularly around the emergency room. I mean, when you go to the emergency room, you're triaged, and somebody assesses you and scores you, and they make a decision on the severity of your condition. So sometimes people sit there and say, well, gee, I've been here for 12 hours, and this person came and they were rated, and well, that's because they were triaged at a different acuity level. So you're right. Maybe people knowing that, I also think that maybe there's an opportunity just to be honest about the way they've been triaged. Hey, we've triaged you this way. You're going to be the last person seen in here. So do you want to go over here and use the virtual system, or do you want to, we'll text you when it's time to come back, whatever. There's all kinds of things that are happening in other jurisdictions that we're looking at here. But what I would say is, to your point of, everyone has a responsibility here for sure, whether that's just, trying to encourage somebody, a healthcare professional, to move here, thinking of your great second cousin who's now somewhere else and you want the premier to call them, just ask me and I'll call them and invite them back. I do that every single day. But the most important thing that every single Nova Scotian can do to help our healthcare system, if you have an appointment, keep it. Keep it. The number of people who have appointments and for whatever reason don't show up, and then just don't show up, and then so there's no time to bring somebody else in. It wasn't canceled early enough. So the only thing, if I would ask you to do one thing, if you have an appointment with a healthcare professional, keep it or cancel it in enough notice that somebody else can get that appointment. Because there's lots of, it's not the single fix to the system, but there's capacity in the system that's being wasted because people didn't show up. And so that's more true than others in certain different specialties. But we all have a responsibility to your point, and I love the idea of just communicating better with Nova Scotians about what's happening in the healthcare system and what their own experience should look like. That's the reason that we've put the Action for Healthcare website up there. You can go on and find out incredible statistics about our healthcare system. And people say you can't get a doctor, you can't get an ambulance, whatever. We can go on and tell you what the ambulance response times were yesterday around the province. And most of them are within the required time. Not all of them, but most of them are. So that's back to almost where we started of we want to make sure you can access care. And if you get into the healthcare system in this province, you are going to get incredible care from very, very compassionate professionals who are at the top of their game. We just got to get you in there at the right person.
Thank you. We have a question at the front here, and then we had some hands up around here too. So I think in the back here, and then here, and then we're going to be closer.
Sorry, who isn't it?
Oh, sorry, right here, right front row.
Hi, I'd like to thank you for giving us an opportunity to speak. My name is Leah Sutherland, and I advocate for people that live with type 1 diabetes. And we're here, you asked for solutions. My solution, and I have letters here from many families, and I'm going to read just a partial letter from one typical young girl that's really hit my heart. Solution is
Hold your mic up.
give everyone
Leah, hold your mic.
well, the solution for people that live with type 1 diabetes is to let them have access to the insulin pump and the CGMs. And here is just one letter, and I'm going to give a few other letters to you and Michelle Young. It says, my name is Erica Cousin, and I am 35 years old. I have been living with type 1 diabetes since the age of 9. Currently, I am on dialysis 7 days a week, 8 hours a day. At the end, and I am at the end of the stage of kidney failure. I don't know why I'm shaking. I've done this many times. I have struggled with the management of my blood. I'm going to sit down so I don't shake. I have struggled with the management of my blood glucose levels for most of my life. Due to my current health conditions, this management has been becoming increasingly difficult. I do not recognize when my glucose levels are low or high, and insulin adjustments without fine-tuning that an insulin pump can provide me. In order for me to be considered a candidate for a transplant list, I must have good control of my diabetes. And this is why an insulin pump is, well, she goes on and on and on as her health has deteriorated so much at 35 years old because she doesn't have a health plan. And we talk about the solutions. It's easy. Keep the people out of the hospitals. Let them have management of their diabetes. Thank you.
Thank you, Leah. I know why you're shaking for sure, and I certainly appreciate your. I know why you are, and I appreciate your advocacy on this issue. And I think when we think about it, kind of speaks to the core of a lot of the issues that we experience. We have a healthcare system that was designed generations ago for a certain purpose, and the world's changed. We have a lot more chronic conditions, diabetes and others. And the system really hasn't adapted. So if we can make the proper investments in taking care of those with chronic conditions like diabetes, we'll all be better off for it. Dr. Smith mentioned the Inspired program, which is specific to COPD, but that program has shown time and time again, for every dollar invested in that program, it saves $20 to the healthcare system in emergency room visits that are avoided, hospital stays that are avoided, and I think that's very true in diabetes. So what I would say to you is, I hear you. Our team hears you. I participated in the finger prick challenge, where somebody used the monitors versus the finger prick, and I'm very sympathetic, and I would say stay tuned.
Thank you. So I had a question back here. Yep. Thank you. Yeah, sorry, the pointing. Right here. And then there was someone in the back row. And then if we have time, so I think here, and then.
I'd like to say something a little positive. I have been an RN for 49 years, just recently completely retired. I should take this off. I've seen many changes in healthcare over the years, but one thing that has never changed, and that is the dedication and the quality of healthcare workers once you are able to access the system. The problem of late has been accessing the system. I'm one of these people on the list that has no nurse practitioner or family physician. And I will say that the virtual care, the MAPLE, has been excellent anytime I had the need to access it. However, it is limited. What you miss with that is the preventative care, consistency, and speaking to someone who doesn't know you, because it's a different person each time. But I will say it has met the immediate needs for me. The question I have has to do with this list. Waiting for a physician or a nurse practitioner. And I'd like to know a little bit more about the process. It's been about 3 years for me now, but I'm not in any grave, danger or need right at the moment. But I would like to know more about the process as to how you get matched up with a physician, because there was some physicians come to Pictou County, and I am still waiting, but I would just like to know a little bit more about the process. That's my question.
Oh, so would I. Seriously, it's almost that blunt. it is a list of people who need access to a family care practitioner. We also know some people on that list have one already, but maybe they want a different one, or maybe they want one in their own community. So there's, and the thing that is absolutely true is we don't have a good understanding of the needs of the people on that list. So a healthy 20-year-old who's on that list is not the same as a 75-year-old who's just finished cancer treatments. So there's different complexities on the list. So we don't really, we're trying to really get to the bottom of understanding the needs of that list. And the way people have come off the list is I think just simply a family care practitioner just looks at the list and just takes names off, right? I mean, it's as simple as that. I don't think there's been any kind of real science to it. So we're doing a lot of work to understand the list. Also, and I think the point was made before, is being on that list is not the same as not having access to care, right? So there are people on that list who have virtual, and I understand virtual is not for everything, for sure, and I understand the challenges around continuation of care. It's really important to have a continuity of care, and when you get different people, and a gentleman raised tonight that he didn't have any follow-up from his virtual care when clearly he should have, right? So we know it's not perfect, but we're looking for ways for people to connect with the healthcare system, and then a qualified professional can help navigate them through a little more. But I think I'd be fair to say, and I'll stand corrected, but I don't think there has been any science to how people come off that list. And it's also true, I think, and fair to say that people who may have been on that list and then get connected, not the first thing they do is go on and take their name off the list either, right? So there's a lot of issues with the list, we would say. It is an indicator. It means something. The fact that it's going up every month means something to me. I don't know that it's going up in a perfect amount, but it's going up. And that tells me that there's issues, and the issues are compounding. So it's a directional indicator, but I don't think it's been particularly effective outside of that, if I'm being honest. I don't know if that's too harsh or not. But
Not too harsh. Why don't you just elaborate, Jeannine, what we're doing with the list?
So we're really, I'm sorry, did you have a clarification?
I don't know if this is on. Is it on? So is it just a wait and you hear?
Yes.
Like, that's basically what I was looking for.
Currently, that's the way that it is. But as the Premier said, what we're trying to understand now is it's not working for us, and it's not working for you, because your name just goes on there. You don't know where you are. There could be 10 people ahead of you. There could be 200 people ahead of you.
Exactly.
So what we're trying to do, and we also don't know what condition you may have, what you need access to. So the work that we're undertaking right now is to better understand who is on the list and how we need to triage it. So same as when you go into the emergency room, as the Premier spoke to earlier, we need to be able to attach a triage number to the people who are on the list to say, do you know what? You might have only been on the list for 2 months, but you need to come ahead of the person who's been over here for 10 months because of the nature of your condition and the services that you need to access. So that work is underway. It's complicated, right? I'm not gonna, but we are trying to make it better so that you would have a better idea of where you are on the list, and we have a better idea of what you need from us while you are on the list. So I think the first quarter, Bethany, am I correct? Like this quarter, we're advancing that work. That work has come a ways, and then this quarter we're really pushing it hard. So again, it's a stay tuned one, but we're actively working to make it better for both citizens and the government.
So you just have to wait till you get a call.
You do, yes, currently.
Nova Scotia Health Authority encourages family practices that are able to accept new patients to use the registry. However, not all family physicians use the Need of Family Practice Registry. Family physicians are independent health providers who have autonomy over their professional practice. Family physicians can choose at their discretion how and when they accept new patients into their practice. This can be from the Need of Family Practice Registry, or it can be through other means, for example, their own maintained lists or advertisements. So none of us on the list are guaranteed ever getting a call from the registry, in my opinion.
Okay, but may I just make the point I was going to make? So 3 things, actually 3 points now. First of all, we are doing work on the list. But if you are on the list and you have signed up for virtual care and you have received virtual care and you are referred, you are referred to a primary care clinic and you will be seen there. Okay, so people need to understand if you are referred by virtue of the virtual appointment, you will be seen. So this is number 1. Number 2, so that's wrong. What you read is correct. No, what you read is correct, but that's nuts. That's nuts, right? It's nuts. So what we are in the midst of doing is working with physicians, particularly those whom the province pays a salary. Exactly. So we do have a certain category of physician that the province does pay the salary. So we have a big opportunity to work with those physicians to basically set out how we want them to interact with the list. Okay, so in other words, not a free-for-all. Now, it has been, but it can't continue to be, I guess is all I was trying to say. So your point is a great point. We hear it, and we're taking action. Yeah. And I forget my third point. Doesn't matter.
Thank you. I think we had a question in the back. Someone in the back. It's hard to see, but yep.
I want to just ask one question.
Can you hold your mic up?
Why the ER, you have a skeleton crew, especially in a big hospital like in Glasgow, which is, for everybody, overnight. I'll tell you, a doctor doesn't come in until the morning. That's when you see a doctor. I've sat there all night waiting for a doctor at one time. 15 hours, pretty near. And you have the nurses, that's fine, like everybody is working good. But the thing is, there should be a qualified doctor there on that skeleton crew. What if there was a bad accident out on the road, the highway, maybe 10-car pileup and an ice jam or something? What was going to happen with having a skeleton crew there? If they're taking all these people in there. You're not going to be able to get them to Halifax in time. You're not going to be able to get them to any other hospitals, but Glasgow emergency would have to take them in. You have to think about those things sometimes.
Dr. Smith will respond in detail, but I just want to assure you that there's no policy or governmental directive to put a skeleton crew in an emergency room. If there's a skeleton crew in an emergency room, it's just because we couldn't get the people. It's not because we're trying to save money or anything like that. It's just purely a human resource issue. So that's back to recruitment and retention. So I just want to allow Dr. Smith, but I just want to be, I can't state that clear enough that our government is not about saving money in healthcare. We're about, as Karen said, we're not going to flush it down the toilet. We want to spend it effectively and efficiently to your benefit. So there would never be, there better not be anyway, any kind of directive that says go and save money by putting a skeleton crew in an emergency room, or go and save money by closing an emergency room. If that's happening, it's just because the human resources weren't available at that time. 100%, you're right on that one. There are issues in the emergency room for sure. The point I'm trying to make is it's not by design. The issues in the emergency room are just because we couldn't get the people at that time. But Aaron, maybe go ahead.
So,
Yeah,
I can speak to that. So Aberdeen Hospital is one of the 3 regional emergency departments in Northern Zone with Amherst and with Colchester. Aberdeen Hospital has 24/7 physician coverage. And in fact, as do Amherst and Colchester. And in fact, in times of high patient flow that we can predict, we oftentimes try our best to double up that physician coverage to try to address the waits that you're speaking of. You know, I will mirror what's said before, is that the waits are long, especially if you're in with a condition that is important but not necessarily urgent or emergent. I'll tell you, when you're sitting in that emergency wait room and you're frustrated and it's long and you're worried about yourself or you're worried about the person beside you or your kid and it's crying, you can't see what's going on behind the doors there. And I'll tell you, it's a hell of a lot. There's sick people, there's emergencies coming in ambulances from car accidents, as you said, and other things. But also there's people who have come in for assessment. They're admitted, we're trying to get them to a bed upstairs, and the emergency room physician is managing that situation behind closed doors. So I completely acknowledge it's frustrating and it's hard, especially, like as you said, if you've had to wait all night. But you know, there is excellent care being provided by a very dedicated team, and our emergency department is 24/7 across the zone.
Okay, so I don't know, I always have to remind the panel of how, because they don't keep track of the time, I find, with the panel. So it's 5 to 8, and I know we had one other question, I think, down this aisle. Did I see someone down here with their hand up if there was a final question? Oh, maybe it was written down. Somebody had to leave? Okay. Is this like a mic drop question? Oh, okay. So it's someone that had to leave but didn't put her name on it, so we can't reply back. So we're going to have to read it out and have it recorded, and she can watch her answer. Okay. So it's a question about a gap for managing chronic conditions. The chronic management outdoor does not have a nurse practitioner to help manage liver disease or kidney disease. In order to receive a referral for a liver specialist or a kidney specialist, the person had to go to Emerge and hope that the ER will make a referral. Is there anything that's happening about that?
So certainly, it's hard because the person's not here to kind of get clarification. So certainly our emergency room physicians, when you present, if you do need to be referred to a specialist, the emergency room physicians are able to do that. I'm not sure whether the in terms of your internal medicine, as an example, what the skill set or the specialty are of your local internal medicine, but wherever that doesn't exist in a community, then we would refer to the next community. So, I'm from Antigonish. I know that internal medicine, sometimes the referrals go between the two practices, and certainly our tertiary and quaternary care subspecialists, those very, very specific specialists, exist at our sites in Halifax. So there is a referral process that happens, I guess is what I would say, and it's very easy for them to refer through the emergency room. Sometimes it can be at a later date. It's a referral that's sent, and sometimes it happens more urgently. It really depends on the acuity, how sick you are when you need that referral, is what I would say. So emergency physicians are able to refer to specialists.
Okay, thank you. Okay, so it is really the end of our time, and as I have said a few times about writing your name on it, I was just reminded to also put your contact information. So your name, your email, or phone number, one of the two.
Oh,
we love pharmacists. Yes. I know.
Yes.
No. Yeah. Yeah. So we really are. So what I'll tell you is this is just we think it's a quick snapper, but we might be here all night. So pharmacists are one example of folks who have a really extensive knowledge base and and have an expanded scope. And what we want to do is make sure that pharmacists, we can use them to the best of their ability. So, you know, in the old days, maybe our pharmacists were counting pills and dispensing medications and things in the back. That's what I remember. But the pharmacist scope is well beyond that, and when we do want to use them to the best and highest ability. So in community, you know, as an example, they were the primary deliverers for us for the COVID vaccine, and how they extended our reach available in every single community. They're now doing some prevention work around Lyme disease, as an example, in community, looking at what their scope is. They're able in community to look at basic things like UTI, still really important and need to be treated, but they're able to do some of those assessments and actually prescribe medication for you. And in the emergency rooms and in our hospitals, pharmacists are an integral part of our care teams to look at all of the different ways that we interact. So, and not just pharmacists, like we need to expand the scope of every healthcare professional. And we haven't done that well historically. So what can an RN do? What can an LPN do? What can a CCA do? Pharmacist, physio. And so we kind of say when we're just in our lanes and we're doing things the old way, we can see that we have this much capacity. But when we look at those healthcare professionals and we extend them to the edges of their scope, we have this much capacity. And that's really what we need to do. And we also want, to the best of our abilities, these healthcare professionals working in teams. So if you're connected to a team, you may not see a physician or a nurse practitioner every time. You may see the pharmacist, the social worker, the dietitian, the physio. But what matters is that you're seeing the right person. So that's exactly the work that's underway. How do we get the right people? And pharmacists are such an important part of that team, and I see our in-house pharmacists probably cringing at the back that I've underestimated or haven't fully represented, but we are all in, and the Pharmacy Association of Nova Scotia is an excellent partner for us. So absolutely, we're looking at how we expand and use pharmacists to the best of our ability. Oh, sorry.
Yep. Thank you for that. I think that's an incredibly important point, and the minister makes an important point too, just about allied healthcare professionals across the spectrum. I actually created a list of allied healthcare professionals and sent it to the department and said, do we have every one of these in the province? I think I had 146 allied healthcare professionals on that list, and they turned it around in a couple days, and I think there was 136 of them that are actually operating in this province. So I said, well, I didn't ask the right question, and now I need to ask a different question, is are they working to their full scope? Because I think what you'll find is, and the discussion is about smoothing the load. Because the load on the healthcare system is significant, and we see the cracks popping up every single place. So I use the example of the paramedics and the transfer drivers. We're trying to smooth the load on the EHS system. Pharmacists can smooth the load. Other allied healthcare professionals can smooth the load. Technology can smooth the load. I was quite surprised to find out that we talk about bed utilization in hospitals. A lot of times emergency rooms jam because people are admitted, but there's no bed upstairs, or they don't know where the bed is upstairs, so they're taking up. So that was all kind of a manual system. Somebody would phone somebody, do you have a bed on floor 3? No. Do you have a bed on floor 4? No. 5? No. Back to 3, and around we'd go. So we created a command center. The pilot is in Halifax at the VG, where we actually, first off, put all these people in the same room so they can literally talk to each other, and put massive computer screens up. So now we're actually moving people through, smoothing the load. Leah's talking about a way for people to help manage their own conditions, smoothing the load. So I just want you to know that we are not naive to the magnitude of the challenge that is before us, and we are sympathetic of the fear and the emotions that have brought you here tonight. You know, listen to come here tonight to listen to politicians talk. Nobody wants to do that, but you're here because you understand and are concerned about the state of healthcare in this province and in this country, quite frankly. So we hear that and we feel that, and your presence here tonight sends a message to us. Work harder, do better, go faster. We received that message from your presence tonight. But I hope you also receive a message, is that the people running the healthcare system, the people delivering care to you, the person that you end up speaking to at the emergency room, or when you call EHS, or when you call Maple, they care about your health too. They really do. And they're overworked, and things will happen, but it's not because nobody cares. And it's definitely not because nobody's trying, because people are trying. And we'll try harder, and we'll work harder. But we all have a role to play in that. We talked about that. But I don't know if you had a wrap up, but what I would say is, for me, just thank you for your commitment to your community by being here. For me personally, thank you for your belief in me and putting your trust in me as your elected MLA for this constituency, and also as your premier. It's an incredible privilege. I feel the urgency. I feel it, because I know that this is a period in time. I'll be premier for a certain period of time. You guys will decide when that period of time is up. You or Carol or my wife or somebody. But what I don't want to happen is, after that period of time, I don't want to spend the rest of my life thinking you were right there and you could have fixed it. So I am completely driven every single morning when I get up to do what I can to fix it. Because when I read these challenges and this terrible situation that happened in Amherst, and I see your faces of people I've talked to about your own personal experiences, and it motivates me tremendously. So please don't give up. We are not giving up. We are working harder, and we are more committed. So thank you for being here tonight, and thank you for this incredible team.